writing is against. Now let's move on to the troublemaker board that can confuse the hell out of you. But before we do that, I want to give you a summary of what we're about to talk about with that busy board. Don't worry, I am not going to erase this because I need everybody to copy it. Whether you do it at the break is up to you, but I don't want to erase not even one part of that because I really want you to get it. I'm only going to erase the little notes I just put on there just because that you already know what we were talking about with that. But yeah, man, you got to copy this shit. Okay, so here we go. We're going to turn this board to summarize these next two boards. I still have another freaking board behind this one. I know, baby. Call the final, girl. You're going to be all right. Ain't supposed to be easy. Got to take care of these people's lives. Okay, now I got a summary for y'all up here and even here. If you take out your Rome packet, you can put away your procedures packet. If you take out your Rome, you can put away procedures. You're done deal with that one. I suggest when you have a minute, because your final is what days? Wednesday next week, right? Or Monday, okay. So I suggest you glance at those handouts. The procedures handout has other things in it for your other subjects. It's got dialysis in there. It's got everything in there. Okay, so it's got procedures. Hello. All your testing. You know, it's got, I don't know, clean catch in there. It's got a bunch of shit in there for all kinds of subjects. It's a procedure packet for every subject. So you're going to keep that handy. This one here is strictly acid base and electrolytes. Now, if you flip your entire packet over, the Rome packet, flip the whole thing over. What's on the back of yours, baby boy? What's on the back of that? What's it say? Hyponatremia? Okay. You guys probably don't have anything on your back, and that's fine. Not a big deal. But if you don't have anything on your back, and certainly you have room at the bottom, so you'll be fine. I know that you guys probably didn't have this when I did your lecture, but when I do your final, it's a summary. So let me tell you about this summary, and I would like you to record that in there or write that in there when you get a chance. You can write as I talk, because I'm going to, talk about it at great length. When we look at electrolytes, it's based on relationships. Either they're married or divorced. Having been married 18 times, I can tell you a little bit about both. So, not really, but God help me. Well, close. Okay, so here we go. Potassium is divorced from sodium. They don't like each other. One goes one way, the other goes the other way. So it's a nice general rule, and let me just emphasize general. 90% of the time, if your K is high, your sodium is low. 90% of the time. Now, as it goes with real people, because a textbook is one thing, real people's another. As it goes with real people, our typical patient is high K, low sodium. Typical, the ones you're scared about the most are high K and low sodium. Now this gets confusing, so I'm just going to keep reminding y'all every 5 seconds that hyponatremia is SIADH. I'm just going to keep saying that. You might want to write it. Yeah, you probably want to write that about 50 times. So if I'm telling you that the biggest people to worry about are the patients with high Ks and low sodiums, I'm also telling you to worry about SIADH, which we treat with 3% sodium chloride or hypertonic solution. So just hooking you up. Now, so the K. Let's focus on the K. The first one is K. When you have potassium issues, and it really doesn't matter if it's low or high, it doesn't matter. You're going to have heart issues. So it doesn't really matter if it's high or low. Either way, you're going to have heart stuff. So all potassium troublemakers get an EKG. Whether it's high, low, whatever the hell it's doing. All of them are going to get that EKG. Because it's going to affect their heart one way or another. And we'll talk about what way it affects it on those boards over there. But for right now, you know it. Here's our other problem. It can also affect your GI. Because whenever we talk about electrolytes, you can't talk about electrolytes unless you talk about muscle weakness. All electrolyte imbalances, no matter which one, are going to give you muscle weakness. Most imbalances are going to give you seizures. 90% are going to give you muscle weakness. So we can't even discuss this crap unless we remember the muscles of the body. Well, the best and most important muscle of your body is your heart. It's a heart muscle. The other one is a diaphragm. It helps you breathe. So you can see why electrolytes are crazy. Okay? So the muscle of the heart depends on potassium. The muscles in the GI system depends on potassium. So think it through. If I got too much potassium, I'm having too much muscle activity in the GI, and we just doing big things, moving all fast and shit, diarrhea. If I don't have enough potassium, I don't have enough muscle activity in my GI, I'm barely moving. So I'm constipated. Or I have a bowel obstruction. Or worse, an example of a bowel obstruction, a paralytic ileus. Because potassium controls muscles. So again, if I don't have enough, I really don't have a lot of muscles in my GI system. That's called lack of peristalsis. If I have too much, I'm just doing too much in there, right? I'm muscle all over the place, just moving too fast. That's what diarrhea is, it's moving things too fast. Okay? Renal. You got two problems here. When your kidneys fail, you have too much potassium because the only way to get rid of it was to pee it out. We all agreed on that on Tuesday or Monday or whatever the hell I seen y'all last. They all go together. I've been here every day. On the other side of the board, if you give me too much potassium, you killed my kidneys. So when I have a patient whose lab comes over and it says low potassium, and I order KCl or 20 of potassium in the IV bag, when I order that as a provider, the nurse, she can't just go running with my order and do it. Oh no, honey, she's got to make sure her patient can pee. Because if her patient has borderline kidney function, and she doesn't know that because we're an ER patient, we just walked in off of nowhere, and she just, oh, Shelly ordered potassium, and she runs in that room and gives that patient with borderline kidneys potassium, she just killed the rest of the kidney function off. No potassium unless you can pee. So what do we say? No pee, no K. No P, you ain't getting no K. You have to prove to me that you can actually pee. Now, I got a girl that left up out of here. She was first she came to me for tutoring. That was Trice's tutoring. Then she came in for NCLEX review. And then she hung around like she was genital warts. And I said, girl, go get a job. You can't sit around here all day. I just want to help you. No, honey, you got to get a job. I can't find a job in the hospital. Well, that's the way it is. You're at the end of the year. They got a little hiring freeze at the end of the year. They're going to open it all back up in January. Go get any old kind of job, child. Nursing home, whatever. Do what my daddy told you. My daddy told me it's easier to get a job if you got a job and don't quit a job till you get a job. So I told her to get out here and get a job. She got a job. She got a job in a nursing home. She learned midlines and everything in a nursing home. And within 15 minutes, she got the job of her dreams. And then everybody called her. That's how it's going to go. So I told her, quit that shit. Go get that shit. She went over there to Murder Mount. Got a job in the ER. She gets a patient, and the doctor orders potassium. And she's like, Shelly said, no P, no K. The patient hasn't peed yet, and she keeps giving them fluids. You have to pee? No. She doesn't want to catheterize them because you and I both know that's a route for infection. So here come the doctor yelling, come on now, did you hang the potassium? What the fuck? You don't have the K hanging. I know, I just got to make sure she can pee, okay? You want me to cath this woman for pee? Oh, no, I don't want that. Well, then hush. So she eventually peed, and then she hung the K. But she ain't stupid. She know what I taught her. Don't lose your license over stupidity. Do not pay potassium unless you're positive that your patient can pee. Okay? Now, so you got your renal. Too much K can kill it. On the other side, too much potassium can kill it. Sodium. Well, shit, we talk about that constantly because I keep saying SiADH. Typically, on any given exam, you don't get a high sodium patient. You get the low sodium patient because that's your SiADH, and we have called it water intoxication. Well, the problem is sodium controls all your nerves. Yeah, muscles a little bit, but you want to remember nerves. It's a neuro issue. So if I don't have any sodium, I'm going to have neuro symptoms. I'm going to have something going on with the head in terms of a headache. I'm going to have something going on with the head in terms of ICP. I'm going to have something going on with the head in terms of seizures. That's just real. Okay, so you've got to remember that. Okay. Moving on to calcium. Oh, hell yeah. One of the most important ones on the board outside of potassium. I know for a fact when I see your little cute faces 10 years from now, and you're in Walmart, they're going to still be around. You know they're going to still be around. You're in Walmart shopping, buying all that stuff made in China. And I'm over there across the river in a whole other aisle buying some more stuff made in China. And I happen to see your face, and I know my babies from everybody. Hey, girl, how you doing? Hypocalcemia! You know what you're going to shout? Loud as you can. Technique, Shabbatics, Trousseaus, Briss DTRs, and Clonus. Promise you, you're going to say that. And yes, I do test your ass 10 years from now. People came in here and they say, she does. It's so embarrassing. I don't care. You can't forget this just because the test is done. This is a real person. What in the world is tetany? Write this down. Tetany is spasms of the mouth, the face, the throat, which is called your pharynx, the voice box, which is called your larynx, the top of your lungs, which is called your bronchia. So pharyngeal, laryngeal, bronchiospasm. That's what it is. And it is an emergency. It kills you. Okay, so it's a bunch of spasms. And it can give you stridor, and it's just horrible. You don't want to mess around. It's going to give you numbness and tingling. Don't forget that. Write it down. It's going to give you numbness and tingling. Paresthesia. You know that's numbness and tingling. That's what tetany is. That's what it's going to do. Shabbatics, it starts with a C and a H. And I tell you to remember C and H for cheek. Because the nurse who's assessing for Shabbatics, she's going to take her fingers and tap on the cheek, right in front of the ear. CH for Shabbatics, CH for cheek. She's going to tap on the cheek. If she gets twitching of the mouth or the face, this is a low calcium. And like I said, 90% of people follow my letters. That's what they're going to have, a low calcium. 90% of tests, 90% of people. So ain't even no sense in me giving you a high calcium patient because it's so rare. It's the low calcium you got to worry about. Okay? Now, trousseaus. Trousseaus is where you put the freaking blood pressure cuff on and you inflated it and the patient's thumb flexed inward, looked like they had a claw thing jumping off, and this is how they look. And all you did was inflate the cuff, and you get this crazy looking kind of claw fingers. It's just, it's absolutely ridiculous the way it looks. It's really profound in these patients with a low calcium. Now, brisk DTRs. You come in there and do what I told you. Now, I done already told you, some of y'all don't know, but I done told most of you, there's 3 tools for every nurse, real nurses. You never go anywhere without your pen light, your Littman stethoscope, and your reflex hammer. So you got your reflex hammer, because you're the bomb.com, and you tapped on the patella, and that patient kicked your ass in your chin. That would be brisk, deep tendon reflexes. 4+. Don't forget to write it. It's called 4+. You and me sitting here, some of y'all dead as hell, but that's all right. But you and me typically, the ones that are awake and alert and oriented, we are 2+ deep tendon reflexes. This patient is 4+. Now, the problem is if you want to do it like that and have 4+ brisk reflexes, you're going to kick me all in my chin and all this, then you've got to check for clonus next. So we got to get our patient. Hold on. Got to get our resident patient. This here is our resident patient. How you doing? My name is, you don't care. You tapped on the knee, patient kicked you. Okay, cool. I do not check for clonus unless I tapped on the knee and the patient was doing too much. They were too brisk. I don't check for clonus on everybody. Ain't nobody got time for that. But when they do, the next step, everyone, is clonus. So here we go. Take your hand, grab the bottom of the foot, dorsiflex it back to the nose, let it go. As God is my witness, my pre-eclampsia patient, who is definitely a risk for seizures, and you got that patient next semester in 2300, you grab the bottom of her foot, my patient, I let go, she taps me back. That's crazy. So clonus is when I dorsiflex the foot, I let go, she's tapping me back. I have to count the beats to know how severe, and again, my patient was 4+. So clonus, 4 beats of clonus is how I documented that in the notes. Brisk DTRs, 4 beats of clonus, stupid shit, it's crazy as hell. So we know that she's going to have a seizure any second now. Okay, that's scary as hell. Okay, all right. Now, so what are we saying? All 5 of these equal seizures. Make sure you're right. All 5 of those equals a seizure. Okay, more love. Here we go. Just more love. 99 times. This is bigger than 90%. 99 times out of 100. If the calcium is low, the phosphorus is high. 99 times out of 100, that's how it's going to go. And if I want this patient to increase their calcium, I would certainly have to lower the phosphorus. Do we agree? Okay. If I want that. If I want to lower the calcium, give more phosphorus. If I want to raise the calcium, give less phosphorus. They're opposites. You're not going to get my calcium up by giving me high phosphorus. They're opposites. You have to believe they're going in opposite directions. They're divorced, for crying out loud. They're just divorced. That's all you can do. You got to keep them away from each other. They're not going to the graduation together. They're not going to a kid's christening. They hate each other. Okay? Now, who's married to salt, water, and they like each other still? They're not like unhappily married. They're happily married. They still go places together. So wherever the one goes, the other's going to go. So far, so good? Okay, moving on. This is a huge, huge trick on any electrolyte test. Magnesium and calcium are the same. Typically, they give you the same kind of goofy symptoms. They flow in the same people. They're the same. So if I'm low in calcium, I'm probably low in mag. Alcoholics are low in both. I would write that. Alcoholics are low in both. So they're married. They have a nice little symbiotic relationship. They're married. Okay. Now that board over there is going to make more sense now.